So the next topic is an area that we think offers a huge opportunity, real-time opportunity, and what I would call I like to use the term speed to impact. This is an area that we're going to talk about imaging today, but this applies to laboratory testing and many areas of medicine and care that we have delivered today. What we had done, and a number of us in a program called a Green Light program, is a group of really high-performing hospitals that have great core values that we handpicked, and we said, let's work together on the things that we can target and really be able to verify clinical, operational, and financial performance by applying best and better practice. And they had the talent and the desire to do that. And we started with infections. And so we created impact calculators on infections because, we had in publications, well, an infection we give patients is anywhere between $1 and $1 million. So go ahead and figure out, what your ROI is going to be when you reduce them. And I was constantly hearing from our 3,100 hospitals, well, we don't know exactly, how can I go to the boss to get funded for a project? And then we learned the tough lesson that in order to get the green light, and it comes from the movie industry, a green light movie is when you have the funding and you have the talent and everybody's ready to go and you have kind of a little bit of a party and you say, we got a green light, let's go make a movie. And so we thought, you know what? We need to figure out how to get the votes for the green light on safety and quality projects. And it turns out that the chief operating officer and the chief financial officer are the dynamic duo that kill many of these projects. I don't want to be pejorative, but they're responsible for the dark green dollars. So the CFO is keeping account of all those dark green dollars, and the COO is talking about capacity, and we would put great projects together, and the CEO would say, this is great, and this is how to beat the other guys in town, or this is how we can be great and wonderful. And then the COO and the CFO would kind of shake their hands and say, boss, you told us to get the budget, and then it would kill the deal. And we said, doggone it, we're so frustrated with this. And our special sauce and what we do is healthcare services, engineering, and tying clinical, operational, financial together. So we did it with infections, and it really, really helped our hospitals. I think at the Mayo Clinic, it helped us really understand, and Dr. Bob Sema worked tirelessly on it, and team at Cleveland Clinic and the folks at Harvard. We all worked together to figure out what kind of impact we could have, and it really helped us understand how the clinical, operational, and financial fit together. And so what happened was then we focused on imaging. And so we have this wonderful opportunity in imaging that actually can translate immediately to laboratory, and it's the 5 rights. And basically, you all that saw the movie this morning, we addressed the 5 rights framework. Public domain, free, providing it out through medical articles, but trademarked so that others can't change it, so that we can keep the focus on each of the 5 rights in a proper manner and can write articles about it and build a body of knowledge. And basically it's the right study, the right order, the right way, the right report, and the right action. And most of our radiology departments for years have been kind of a just say yes department. You'd get an order and you do a study, and we worked with hospitals that had the radiologist would say, I read 22 normal CT scans of the head. I think there's a problem in the emergency department. Yeah, there is. And so this was a way to go all the way around the loop. And then working with Dr. Swensen, who's a radiologist, and other radiologists around the country and around the world, and working with the World Health Organization with Ed Kelly and the team at WHO, and a number of organizations, we focused on each of these rights. And it turns out that if we take CT scans, we'll do 80 million this year, likely 240 million globally, and it's likely that we're probably overusing CT by 20 to 30%. And if we then go around the right order, anywhere from between 30 and 60% of the orders are misordered, or it's in inappropriate order, wrong information, incomplete information, and not the information or the technique or the requirement of the radiologist. If you go down to the right way, We've all seen the news about accidents when patients have had high doses to their brains and to other organs, and now we're really sensitive to radiation safety. And then the right report. I'm a radiation oncologist. I treated cancer for many years, had a really big practice, and I can tell you that the breakdowns all the way around would impact my patients every single day. And I was the largest, I ordered the most studies in my field, in the community where I was. And then the right action. It turns out that not all the doctors get the reports. They're not part of the medical record. If we don't invite the patient into the medical record, they have no way to verify it, and they're one of the best ways to tackle it. So this topic is really to kind of address those issues and what we've learned. And Steve, you're in charge of leadership for Mayo Clinic, but you still see CT scans. You're a specialist in chest CT and a real specialist in the screening and understanding the risk-benefit areas. And you've been doing some great research. Can you share with us, the latest learning in that?
Sure, Chuck. I think we should start with understanding that CT over the last 4 decades has saved countless lives. It's a good, valuable diagnostic and therapeutic device if used right. The opportunity, though, to improve the care of patients is on maybe 10, 20, probably 20, 30% of those exams that don't need to be done or are done the wrong way. And that's where we're doing harm to patients. We're doing harm with the cost, the anxiety, and the risks of radiation over decades. So the New England Journal that look at the radiation exposure would project from the number of scans we do in this country that 20 years from now we'd have about 6 preventable deaths a day from patients who were radiated who shouldn't have been radiated or had the wrong dose. So there are a number of approaches we can use with this. I think we should start with having the patients be the best partner and advocate for themselves and have them ask 6 questions before they come in. They say when a CT scanner is ordered, the first question is, how will it affect the decision? Is it just interesting or nice to know, or is it a really need to know? If it's a need to know, will ultrasound or CT give you the same answer? And then the second question is, do you, the person ordering the exam, have a financial conflict of interest? Will you make more money if you order the scan? The third question to ask is, what's the accuracy rate? If it's a CT for colon cancer, if they don't know the percentage or it's less than 90, walk down the street. Another question to ask is, what's the dose? When we do screening for lung cancer at Mayo Clinic, the dose we use is 36 times lower than the average CT scan dose of the chest. And we still see lung cancers as big as a sesame seed. So you don't need the regular dose to do most of the diagnostic exams we can do. And then finally, I'd ask you, do you do double scans? The vast majority of, as we do a without and a with, it doubles the radiation exposure, and there's a huge amount of variation in the dose in those double scans in this country. They should all go away if the answer is that they're an outlier in that, which half the country is. Walk down the street and find another place. So we found that engaging patients with shared decision-making, this would be a crude form of it, reduces, it improves the satisfaction, reduces cost, and without affecting the safety or the outcome of that patient. So engage a patient. As patients, ask those 6 questions, and that's where we can start to reduce the overuse and the misuse.
And what we've learned about this radiation is that yes, we want to minimize it as much as possible, and unconflicted was what we put in the movie. Unconflicted, meaning no relationship with industry, experts disagree as to how much is enough to cause harm, but they also agree we should minimize it wherever we can, and that we should never miss having a study that could really help us and prepare us for surgery or identify a cancer without taking the risk-benefit decision into consideration. Now, that's a loaded question. Risk-benefit decision. The majority of doctors in America have no idea what a millisievert is. They have no idea even what the stochastic, story is on on back calculating what the risk could be, and most people that aren't in our field with training in radiology would even know that. So the other thing that we had in the film this morning, which Dr. Sofa addressed, is that 88% of the high-tech studies are ordered by doctors that order less than 5 a month or less than 1 a week. Any one of the high-techs, which means they can't keep up on the indications. To me, as an entrepreneur, social entrepreneur, commercial entrepreneur, that's a huge opportunity for education, but it also is a big gap. And so there's something really great that we could really tackle here. Mike Williams is one of our best trained hospital CEOs. He runs a hospital in Fredericksburg, Texas. He has an MBA. He's a specialist anesthesia, critical care, and also did a master's at Harvard. And we got together with Sully, actually, and that's how we all met together. We briefed Mike's team on the 5 rights of imaging, and actually some of the issues, and for those in the audience globally, they can't see what we have up on the screen here, but we have Image Gently and Image Wisely. These are national programs to make sure we're using the right protocols. And with a 30 to 45 minute briefing of your radiology department, within 2 to 3 weeks, tell the story. This is an example of what's going on in America today. Just to know about some of these dose reducing approaches and duplication of studies.
Well, after we had a conversation with you, Chuck and Frank, we had a simultaneous event where we identified a patient event where we had a 5-year-old who came to our hospital who we identified as having sequential ER visits at different hospitals, and we totaled it up and had 7 abdominal CAT scans over his 5-year history. I'm not a radiologist, I'm an anesthesiologist, but my guess is that's got to be close to a lifetime dose total, but it's a lot of radiation, I'll put it that way. It became clear to us there was no communication between our sister hospitals in our area, and so we did what I believe Dr. Henderson said in the movie this morning. We talked to the frontline staff. We took the information that Chuck and Frank had given us, and we then started removing the barriers to let them go to work. And our staff on their own identified ways they could communicate with physicians. They met with vendors. They met with people in the staff. They signed pledges to adapt to Imaging Wisely, the Imaging Wisely campaign, and as well as they took it to the ER on their own without my knowledge. I got a call from a sister hospital CEO. They contacted other hospital radiology departments, asking them that they could set up a communication data line so that when a patient showed up at our ER, they could double check to make sure what studies they'd already had. And so the line got set up before I'd even know it happened. They took care of what needed to be done, and since that time, we've identified many studies that have been completely eliminated prior to initiation, and have really reduced a significant number of pediatric studies that weren't necessary. And on top of that, now our radiologists are involved. It's become really a back to the 4 T's. It's become tell the truth to our patients. We now give our patients a card, much like Steve talked about. This goes with their driver's license, and on the back it has a log where it tells the facility, the exam, and the date. They can log it, take it with them wherever they go, and tells the studies that they've had, how to get a hold of us. And the questions we ask, we're from Texas, so we can only handle 3 questions. Why do I need this exam? How will it improve my health care? And are there alternatives to this study? And so that's, thank you. But again, I was smart enough to get out of the way. Our frontline staff did the work, and it's been a wonderful success, and it continues to grow and expand in terms of a model for what else we can accomplish, I think.
And one of the things, does this cost money? And the interesting thing is that the entrepreneurship of your team, it didn't cost almost anything to put a bug on the screen of the sister hospital that isn't even part of your system, just a nearby hospital, to allow to cross-check on CTs on kids and adults. And it didn't need a data exchange, and it didn't need a $100 million system. It just needed to have the intentionality to reduce dose. Now, we know also from the studies that when doctors own radiology equipment, they order 4 to 7 times as many than the doctors that don't. So is there a motivation there? Absolutely. Is there a financial incentive there? And will that make the headlines? Absolutely. The reason we got into doing movies is nobody's telling the good guy story. Nobody's telling the role model of the good guys that are doing this kind of stuff. All you hear is the headlines of the avarice of the doctors that own the equipment, because that makes the headline, or the catastrophic accident that burns patients. And I think we need to be telling these role model stories that actually leadership didn't cost any. I mean, this just doesn't cost very much money.
No, it didn't.
It's just understanding what the 5 rights are. And it's kind of fun in that we interviewed like 3 or 4 radiologists to go through the framework of the 5 rights, and we end up with the ONC medical director ended up telling the best story, so we put him in the movie. So David, you've talked about imaging being kind of almost the locomotive to pull the EHR. Your thoughts?
Well, you know, everyone knows in all the different specialties that radiology is really the nexus of so many, it's the intersection where so many things cross. And the radiologists in many communities, they really know, they have a good sense of the hub of what's going on, because everyone gets some type of x-ray, and they know the specialists, they know everything. So one of the things that we found is that the radiology department is an opportunity to actually afford some of the best health information exchange, whether you do it with a dedicated line or an HIE or just with a telephone. The information that can be garnered from just allowing the radiologist to exchange information about what's going on with the patients is absolutely profound.
Trisha, your experience, what we didn't tell about Trisha is that she's really been able to have a voice with patient advocates and create a system and a way for advocates to really help patients and families as they go through their trajectory of care. And I've taken advantage of this network 3 times to find people that would help patients along the way. The 5 rights are impossible unless you're an engaged patient, or if you can't be an engaged patient, have somebody advocate for you. Because there's no way, one of the things that we've learned about chronic illness, if you're over 65 and you have 5 chronic illnesses, you'll have 50 doctor visits, or you'll have 35 doctor visits, 50 prescriptions, and you'll be treated by 14 doctors in America. Do you really think that they all got the imaging studies and the laboratory tests? Is there any way any IT system could keep up with all that unless it was totally integrated like Mayo Clinic or some totally integrated organization? No way, but there's one way, and as a cancer doctor, the way I got the records from A to B to Z was with the patient and the family. You've got to trust them to trust you in order to get that to the next step. And until we're completely wired, we have to do that. Just like you came up with a really simple, simple solution. So Trisha, you're, whatever you'd like to comment on, but I think that you've built a network of people that actually can be an assist to people that can't be fully engaged on their own behalf. They might be older or have some illness.
Right. Well, I hear a couple of things that I would like to comment on to then interface with the thing about the advocates. And that is, I love shared decision making. I've written about shared decision making. I know people who are doing that as a living now as shared decision making as private advocates. The problem with being a patient and engaging in shared decision making with the doctor who's recommending you do these things is that the minute you question the doctor who's recommending you do these things, in some doctors' eyes, you've destroyed the relationship. And how can you then move forward in that trusting relationship? The minute you say, do you have some kind of a financial stake in, do you own this machine? That's the end of the relationship. And so even though I love the idea, it's an impractical idea in most cases. I love hearing that there are people, and I agree with you, Chuck, we have to tell the good stories. I usually hear the bad stories. And I love hearing the good stories, but the reality of the world is most of the time it's not necessarily. It's more about we can get reimbursed for that if we order that scan. So let's now take that to somebody independent. So the organization I started is called Advo Connection. You can look it up, advoconnection.com. If you need a private advocate to accompany you to the doctor, sit by your bedside in the hospital, whatever it is. Right now we have about 300 active advocates across the United States and Canada And I support them in their business endeavors because guess what? Most of them are nurses who burned out in the hospital or burned out with doctors, and they want to do something entrepreneurial and they don't understand business. So that's actually the thing I do. But they are an independent voice. And so to the extent somebody can have an independent person asking these important questions, because they are vastly important. Otherwise, you destroy the relationship with the doctor, and I don't know how you overcome that. It's not really so simple as going down the street, even though that is the right answer.
A couple of quick comments. First, one of the people that came along with me when I started was my radiologist, Mark Sands. And you know how radiologists are always in the basement and hidden, no one really looks. Well, it rapidly became one of the best and most functional quality safety parts in the hospital under his sort of leadership. So I had a radiologist who really got on board. In this particular space, I think the whole issue of the necessary studies is huge. So what we have done is we take, rather than our radiologist sit there reading scans all day, every day there's someone out triaging cases coming in. Are these the right studies for this patient? If there are questions, calling the referring doc, saying, this is what you really want, what you're trying to get at. So we pulled someone out of the revenue generating part to the triaging part for effectiveness. And along with that, it's optimizing the studies. I'm no techie in this field, but we've got 60 scanners across the health system. They're all different, how they're set up. Are they really all set for their optimum settings to minimize, and what are the protocols standardizing how we do all the scans? And I see the data now coming through, and it is dramatic how the dosing has come down, how the number of studies looks a lot more, I think, more appropriate. So it's these little bits that have built into a program that looks at the appropriate utilization, referral patterns, and then the way the scans are getting done. And I think it's just building these component bits. So when you put this out, I thought, oh, well, how do we fit into the 5 rights as we move on through this? I think it's a great program, and I think we all should be building on the steps that you've outlined.
Well, I know Ed Kelly's not on our panel, but we're working closely with the World Health Organization, and we know around the world we have the same identical issue. We have the same issue with laboratory, and if we do believe that we have 30% waste conservatively in the system, and we have to convert that 30% of $2.8 trillion into value for our own nation and then the nations across the world, this is a great place to start, because the other part that we didn't mention, and David, you and I are radiation oncologists, is the incidental OMA. Now, the incidental OMA is a term that we always use when we say it's a finding that is a mass and we are not sure what it is, but now we're honor bound or we're malpractice protection bound to now do a whole set of new tests for something that we didn't need to get in the first place. And that isn't even factored into many of the calculations and we're doing it now. We're actually mapping the trajectories of the incidental OMA and say, well, what does that cost? And once you start to change reimbursement so that you're paying for a whole population, no longer do you want to have, you won't have to ask the question, Trisha, of do you own the equipment? You might ask the question, I hope you own the equipment because I know you're not going to overuse it, because it's just going to cost you now, right? The whole thing's going to turn around completely if this ACO or whatever term is used. But David, you and I, dealing with cancer, are probably one of the top referrers for high-tech studies, for sequential studies to monitor the care that we deliver. I retired a long time ago, but there's a huge opportunity, isn't there, to even better the care that we deliver, even if we order the same number of studies. But if we do the 5 rights, aren't we getting better care out of the dollar that we spend?
Absolutely. I mean, more focused care is always better care, and we have to deal with the humbling reality that every test that we order is not 100%. There's false positives, there's false negatives, there's adverse consequences to it, and oftentimes patients and the population at large really do think that these tests are either yes or no, and there's a lot of gray areas with these tests. So And you know, radiation was only discovered a little more than 100 years ago, and it is amazing the progress that's being made with the visualization capability. So we are seeing things at the 2 and 3 millimeter level that really are nothing, and it causes quite a lot of consternation, mainly for the patient, but you're mobilizing a lot of unnecessary healthcare resources for sure.
So as we round out our panel, we'll go to Dr. McDowell, who's first up now, and he was in the movie that you all saw. Now, I've known Dr. McDowell for a long time, and he's a 4-time specialist. He just kept adding to his credentials. But he is a urologic oncologist, anesthesiologist, pain doctor, and really can help us understand, as we talked in the movie, for those that haven't seen it yet or will see it on Discovery, that pain is something that everybody owns and nobody owns. It's also an area of huge overuse of imaging studies. So we talked about the fact that if physicians own the equipment, they order 4 to 7 times as much. And we also know that the image or the Choosing Wisely program, which I've mentioned during the day, which I'm very proud, I'm proud of physicians and societies standing up and saying, we're doing too much testing. I can't tell you as a recovering optimist what that did for me. You know, I mean, I got on the phone, I called everybody, I said, can you believe it? We finally have physician leadership groups that got on the right side of this curve in patient safety and quality. And back pain was one of the areas. So you're our anchor person in this area. Is it not true that we could, if we practice the 5 rights, that we would reduce overuse, but then we also, there's underuse. You know, we can't be kind of like vigilantes to say every study is an excessive study. When we found out that 88% of the doctors that order 88% of all of the orders, this is on 20,000 a day for 35 million covered lives, 88% of the high-tech studies are ordered by doctors that order less than 5 a month. They can't possibly know the indications. You and I would order how many in a day? We knew the indications and we were still catching up on what we would do. So talk about pain, overuse, underuse, and this issue at Gladstone, because it really is a huge opportunity for the nation to cut our cost and our waste.
Sure. Thank you, Chuck. Very happy to be here. This is a great forum that you've convened. I had to smile listening to my fellow panelists. I see so much of this every single day. There's a segment of the non-pain population that will not see a back pain patient unless they have an MRI, because this diminishes the need to talk to the patient, novel concept, and also think, you know, and oftentimes we're paid much more to do than to think. So there is overusage of imaging studies. I think imaging studies should be ordered to either confirm or not confirm whatever your clinical impression is. You know, I mean, somebody with back pain, you can figure out whether they have a lumbar radiculopathy without an MRI. You can treat them if they don't respond, then you go and look for pathology. But you're right, a lot of these MRIs are owned by physicians. The other big problem is that we have a communication gap, because oftentimes a busy practitioner will say, well, you had an MRI, but we've called the radiology department, we've called the hospital, we can't get anybody to fax it, so we'll just order another one. And so, and I mean, anybody who's in clinical practice knows that this is an issue. So this comes to the 1,800-pound gorilla that we've all been dancing around with health information technology, is that they don't talk to each other. My system doesn't talk to your system. The patient is admitted to the hospital and has a study, and every patient assumes that all the information from their hospitalization, including their lab work and their x-rays, were sent to me when they come back to see me. So what we need is an integrated health information system-wide, which I know is difficult to do, but people who say that it is impossible, I say rubbish. Racing did it. Aviation did it. I think we can do it. Everybody reports their taxes on the same IRS form. So I think that we should get health information systems together so that they talk to each other. The Cleveland Clinic has been a model for this. Jim Bajan and the VA system. I can get on a VA computer and I can see a test that was done in Tuscaloosa. I can actually read the x-ray. I actually contracted with the VA system last year to introduce them to some advanced pain management techniques in one of their clinics, and I was really impressed about that, but we don't have that in our everyday hospitals, and patients don't know this. They just assume that we know exactly what has been done. So I like the 5 rights.
And so Gladstone, what you brought up a big issue. Time is done for this panel, but the one issue you brought up that is really important and about the 5 rights, everyone wants to point at malpractice as the overuse problem. And I will tell you it is defensive medicine, but in the research we've done, it's defense of your volume-driven practice. You can't afford to pay somebody to go find the prior study, so you order the study. It's not defensive medicine because of malpractice, it's defending a high volume environment in your clinic. And when incentive models change, just watch how fast the ordering goes down. When you start paying, at the Cleveland Clinic, if you had to start paying for every study that a doctor did for their own convenience, all of a sudden it would turn around. And I think that that's where we need to start to be responsible. And I'm very proud, for once, I'm so proud of the physician groups that got together on choosing wisely, because they were specific, they were focused, and they stood up and said, we need to take care of our own industry. And to me, I think that's great leadership. And I think these are great leaders. So thank you for this panel.